Now, in the fourth section of our lecture, assessment of hearing, we will talk about some special tests which are performed for the assessment of hearing. These special tests include recruitment, short increment sensitivity index, threshold tone decay test, autoacoustic emissions, and central auditory tests. Recruitment. What is recruitment? Recruitment is abnormal growth of loudness. If there is abnormal growth of loudness, that's the recruitment, or recruiting air usually cause the abnormal growth of loudness. And here A is the non-recruiting ear, and then B is the recruiting ear. In this ear, usually the non-recruiting ear, the initial difference, if you see the initial difference between the right and the left ear is of 20 decibels. So here from between left and right ear from 0 to 20, that's the difference of 20 decibels. And then from 10 to 30, it's again 20 to 40 is 20 decibel difference, and then from 30 to 50 it's 20 decibel difference. So it's the difference between the two ears is maintained at all levels. So it's not recruiting ear, it's non-recruiting ear. But on the other side, if you see the recruiting ear at 80 decibel, usually the loudness is perceived by the right ear as good as by the left ear. So though there was a difference in the beginning of 30 decibel initially, so loudness increases and it becomes the same in both ears. So that's the recruitment. Next, the short increment sensitivity index. Short increment sensitivity index is used to differentiate cochlear from retrocochlear lesion. And patients with cochlear lesion usually distinguish smaller changes in intensity of pure tone, and then better than normal persons and those with conductive or retrocochlear pathology. So it's used to distinguish between cochlear and retrocochlear lesions. And patients with cochlear lesions in the cochlea, usually they distinguish how they will be recognized, that they distinguish small changes, very small changes in the intensity of pure tone. That's even better than the normal person. So they are very, very sensitive to short differences in the intensity of the tone. Next was the threshold tone decay test. The threshold tone decay test is measured, why it is used to measure the fatigue of the nerve fatigue. And it is used to detect retrocochlear lesions because it's the measurement of nerve fatigue, or if its nerve get tired, it's mainly for the vestibulocochlear or 8th cranial nerve used to detect retrocochlear lesion. And normally a person can hear a tone continuously for about 60 seconds. So normal person can hear for 60 seconds. So how we interpret this threshold tone decay testing is that if its tone decay is 0 to 5 decibel, then it's absent. Pathology is normal. 10 to 15 decibel is mild, it's cochlear. 20 to 25 decibel, it's moderate, it's cochlear, and if it's more than 25 decibel, it's very, very severe and it's retrocochlear. So threshold tone decay is used for measuring the nerve fatigue and for retrocochlear mainly. So if the tone decay is very more than 25 decibel, then it's severe and the diagnosis is it's retrocochlear lesion. And in nerve fatigue, patients stop hearing early. So nerve fatigue, because once the nerve is fatigued, it stops for working and the patient stops hearing. Next is autoacoustic emissions. Autoacoustic emission is the term used when there is reversal of hearing process. Instead of starting from the external auditory canal and reaching to the cochlea, it's reversed. It's from the cochlea to the external auditory canal or tympanic membrane. So here, when you see, it's a reverse traveling wave set in motion. So hair cells elongate and contract, creating acoustic emission. In the hair cells in the basilar membrane, they elongate, its elongation, and they start acoustic emission. There is reverse traveling wave in motion, and then it causes response passes through middle ear, then emission recorded by microphone in probe, then paired tones presented, stimuli pass through middle ear, and traveling of wave initiated on basilar membrane. So basically it's the emission of waves in the cochlea instead of external ear, and it goes from the cochlea to the external auditory canal. So if we see here in this, it's generated in the outer hair cells, then goes to basilar membrane, then to the perilymph present in the semicircular canals. Then it reaches the oval window, from oval window to the ossicles, then to the tympanic membrane, and then the ear canal. So autoacoustic emission is the emission of sound from the outer hair cells to the ear canal. So it's pretty much the reversal of the normal process. Different types of autoacoustic emissions. We have clinically observed emissions, and then we have subject perceived emissions. In clinically observed or subject perceived emission, clinical observed emissions and subject observed both are spontaneous emissions, which are due to internal sources. So they both can be spontaneous or they can be evoked. They are evoked. Evoked emissions are of again two types. One is linear emissions and non-linear emissions. In linear emission, it's due to stimulus frequency. Its linear reflected emissions are limited to frequency, the frequency at which the stimulus is generated. In non-linear is limited to frequency below that of the highest stimuli. So non-linear. So autoacoustic emissions are of mainly two types. One is clinically observed, one is subject perceived, which are both can be due to spontaneous emissions. And then we have evoked emissions, which can be linear and non-linear type of emissions. What are the uses of autoacoustic emissions? We have this is the screening test mainly in the neonates. and then it tests hearing in uncooperative or mentally challenged individual after sedation, because sedations do not interfere with otoacoustic emissions. So in newborns it's performed in patients who are mentally unstable or uncooperative. It distinguishes cochlear from retrocochlear hearing loss, and it is used after ototoxic effects earlier than pure tone audiometry. So after the ototoxic effects of some drugs, acoustic emission test is better. It diagnosed retrocochlear pathology, especially auditory neuropathy. So all these are the uses of otoacoustic emission tests. Next, the central auditory test. We have 3 types of central auditory test: monotonic, dichotic, and binaural. These are the tests, as the name shows, are used to find out if there is hearing problem of the central auditory cortex or the brain. So in this, usually the electrodes are put on the back of the ear and then on the forehead also. So back of the ears and the forehead. And then different tunes are produced. It can be monotonic, means both ears hear the same sound and same frequency sounds on both sides. And then dichotic is, as the name shows, di is 2. So both ears will hear different messages, different tones, and you should tell the patient they should focus on one more, and then they should repeat whatever they hear from that ear. So that's dichotic, means both ears hear different sounds. Then in the binaural is again 2 different tunes are heard in both ears, and then the brain the person tries to make one tune from those both in the brain. So that's the binaural. All these 3 types of tests are used to find out the abnormality in the central auditory cortex or central auditory tracts and the nuclei. So that was all about the section 3, in which we talked about some special tests for the assessment of the hearing. Thank you for watching sqadia.com.